Hello everybody. Welcome to Number 1 Doctor channel. Today video is about the Mirrizzi syndrome, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel Number 1 Doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about the Mirrizzi syndrome. The Mirrizzi syndrome refers to common hepatic duct obstruction caused by an extrinsic compression from an impacted stone in the cystic duct or Hartmann's pouch of the gallbladder. It has been estimated to occur in 0.7 to 1.8% of all cholecystectomies. It is often not recognized preoperatively, which can lead to significant morbidity and biliary injury, particularly with laparoscopic surgery. Pathogenesis. The gallbladder consists of the fundus, body, infundibulum, and neck. The infundibulum is an area of tapering between the gallbladder body and neck, and Hartmann's pouch is a bulging of the inferior surface of the infundibulum that lies close to the neck of the gallbladder. The gallbladder is connected at its neck to the cystic duct, which empties into the common bile duct. Large gallstones can become impacted in the cystic duct or in Hartmann's pouch. These stones can produce common hepatic duct obstruction, the Mirrizzi syndrome, by two mechanisms: mechanical obstruction of the hepatic duct because of the proximity of the cystic duct and the common hepatic duct, and secondary inflammation with frequent episodes of cholangitis. Classification. There are two classifications that are usually used to clarify the variants of Mirrizzi syndrome and to aid in choosing the appropriate therapeutic procedure. The original classification by McSherry described two types of Mirrizzi syndrome. Type I: compression of the common hepatic duct or common bile duct by a stone impacted in the cystic duct or Hartmann's pouch. Type II: erosion of the calculus from the cystic duct into the common hepatic duct or common bile duct, producing a cholecystic choledochal fistula. A more useful classification system also takes into account the presence and extent of a cholecystobiliary, cholecystohepatic, or cholecystic choledochal fistula, also known as a biliobiliary fistula, due to erosion of the anterior or lateral wall of the common bile duct by impacted stones. Type I: external compression of the common hepatic duct due to a stone impacted at the neck of the gallbladder or at the cystic duct. Type II: the fistula involves less than 1/3 of the circumference of the common bile duct. Type III: involvement of between 1/3 and 2/3 of the circumference of the common bile duct. Type IV: destruction of the entire wall of the common bile duct. Diagnosis. The Mirrizzi syndrome is part of the differential diagnosis of obstructive jaundice. Most patients present with the clinical triad of jaundice, fever, and right upper quadrant pain. The major laboratory findings are elevations in the serum concentrations of alkaline phosphatase and bilirubin in over 90% of patients. Among patients with gallstones, these clinical and laboratory findings are most often due to cholangitis secondary to a stone in the common bile duct, cholecystolithiasis. The diagnostic approach usually begins with ultrasonography followed by calangiography via direct calangiography, endoscopic retrograde cholangiopancreatography, or magnetic resonance cholangiography. Imaging studies, ultrasonography and CT scanning are commonly used in patients with obstructive jaundice. Ultrasonography in this setting generally reveals gallstones and a contracted gallbladder. Features suggestive of Mirrizzi syndrome include dilatation of the biliary system above the level of the gallbladder neck, the presence of a stone impacted in the gallbladder neck, an abrupt change to a normal width of the common duct below the level of the stone. These features can also be seen with endoscopic ultrasonography. CT scanning does not significantly add to sonographic findings with respect to the stone and biliary obstruction, but can be helpful in ascertaining if malignancy is present by revealing enlarged porta hepatis lymph nodes or hepatic metastases lesions. Calangiography. Preoperative calangiography is helpful to confirm the diagnosis and to determine whether a fistula is present. Typically, endoscopic retrograde cholangiopancreatography (ERCP) is used, but percutaneous transhepatic cholangiography (PTC) can also be an option. Magnetic resonance cholangiopancreatography (MRCP) has also been shown to be a useful imaging modality for diagnosis, but lacks the option of therapeutic intervention of ERCP or PTC. Endoscopic retrograde cholangiopancreatography (ERCP) may reveal obstruction of the common hepatic duct, an impacted stone in the neck of the gallbladder or cystic duct. Stone size. Biliobiliary fistulas by the demonstration of the passage of contrast material from the proximal dilated biliary channels into the gallbladder. Duodenal, pancreatic, or ampullary pathology. Features of malignancy. ERCP is superior to percutaneous transhepatic calangiography (PTC) in the setting of Mirrizzi's syndrome for the following reasons. The cystic duct may run parallel to the common hepatic duct and join it far below the usual meeting point. This anomaly cannot be well visualized by PTC but easily seen by ERCP. Significant obstruction of the common hepatic duct. The distal common bile duct may not be adequately visualized by PTC. Preoperative ERCP and sphincterotomy, if necessary for removal of intraductal gallstones, frequently avoid the need for intraoperative bile duct exploration. Biliary decompression by internal stenting can be performed in patients with cholangitis or elevated serum bilirubin concentrations. For those requiring surgery, ERCP can help the surgeon identify the common bile duct as surgery and may reduce the risk of operative injury to the bile duct.